Hello everyone. In this lecture we will discuss about acute exacerbation of asthma, which is defined as rapid deterioration in the symptoms of asthma. This could be triggered by any of the typical asthma triggers which we discussed in the previous lecture, like infection, exercise, cold weather, etc. The patient will present with shortness of breath, which will be worsening over time. They will be using accessory muscles of inspiration to breathe. Normally, external intercostal muscles and diaphragm are the major muscles of inspiration. But if you see a patient using sternocleidomastoid and scalene group of muscles in the neck to breathe, that means they're having difficulty in breathing. Also, the respiratory rate will be faster than normal, which is termed as tachypnea. On auscultation of the chest, you will hear bilateral symmetrical wheeze all over the chest, and the chest will sound tight with reduced air entry. Patients with acute severe asthma are stratified into moderate, severe, or life-threatening asthma. If the peak expiratory flow rate is between 50 to 75% predicted, respiratory rate is less than 25 per minute, heart rate is less than 110 beats per minute, and the speech of the patient is normal, that is, the patient is able to complete a sentence while talking, then we term this as a moderate exacerbation of asthma. But if the peak expiratory flow rate is between 33 to 50% predicted, respiratory rate is more than 25 per minute, heart rate is more than 110 beats per minute, and the patient is unable to complete sentences, then this is termed as severe exacerbation of asthma. In life-threatening exacerbation of asthma, the peak expiratory flow rate will be less than 33%. Oxygen saturation will be below 92%. You will see that the patient is becoming tired of breathing. The respiratory effort is very weak. On auscultation of the chest, there will be no wheeze because now the airways have become so tight that there is no air entry at all. This is described as a silent chest. Also, the patient will go into hemodynamic instability, that is hypotension, bradycardia, and even confusion or coma. Now that you have graded the severity of asthma, you start by giving oxygen to the patient to maintain oxygen saturation above 92%. Also establish intravenous access because the patient might need normal saline for rehydration if they are dehydrated. The standard therapy to treat moderate to severe asthma is to start with inhaled beta-2 agonist. For example, give albuterol 2.5 to 5 milligrams and repeat it as often as required. If the patient doesn't respond well to inhaled beta-2 agonists, then the next step would be to give ipratropium bromide. We start by giving 500 micrograms by nebulization every 20 minutes for 3 doses, or as needed. If the patient is still symptomatic, then you have to give systemic glucocorticoids. For patients who have more severe asthma, you can give IV methylprednisolone, and for patients with less severe asthma, you can give prednisone 40 to 60 milligrams orally. If the patient still remains severe after 1 hour of intensive bronchodilator therapy or presents with symptoms of life-threatening exacerbation, then we give magnesium sulfate 2 gram IV over 20 minutes. If the patient fails to respond to medical treatment and starts developing signs and symptoms of life-threatening asthma, that is slowing of the respiratory rate, a depressed mental status, inability to maintain respiratory effort, severe hypoxemia, severe hypercapnia, or respiratory acidosis, that is pH of less than 7.35, then this suggests that now the patient requires endotracheal intubation and ventilation to maintain the airway. While you're treating the patient in emergency, you have to continuously monitor them to see if they're responding to the treatment or not. The parameters which you can use to monitor the patient are respiratory rate, respiratory effort, peak expiratory flow rate, oxygen saturation, and chest auscultation. Some additional points to remember in the treatment of exacerbation of asthma are that although arterial blood gases help in the assessment of hypercapnia or impending respiratory failure, you should manage the patient clinically without waiting for ABGs. Also, hypercapnia usually does not occur unless the peak expiratory flow rate is less than 25% of predicted. Chest X-ray is also generally unhelpful. You should ask for a chest X-ray if you suspect any complications, for example, pneumonia, pneumothorax, or you're uncertain about the diagnosis, or if the patient is high risk, for example, IV drug abuser, immunosuppressed, has chronic pulmonary disease or heart failure. Discharge a patient with a clear asthma action plan. That means that the patient should know that what could trigger their asthma attack and what is their long-term management. Consider prescribing a rescue pack of steroids to the patient to initiate in the future if they have another exacerbation of asthma. NICE suggests referral to a respiratory specialist after 2 attacks in 1 year. That's it for today. If you found this video helpful, then press the like button below, share it with your friends, and keep following me for more educational stuff. Take care. God bless you all.